So stemtrac as a prediction of metastatic disease. This is a patient who was diagnosed with colon cancer. The initial diagnosis was April 24, and surgery also April 24. It was a large tumor with lymph node infiltration, and the metastatic status was not known. And we investigated the circulating cells for circulating cancer stem cells, and again, together with liver metastasis was detected. Unfortunately, we didn't test the patient before. The stem cells were at a very high level. Next is a patient with already metastatic lung cancer with a small tumor, but involved lymph nodes and known metastasis. And before the start of therapy, we could detect a high number of circulating cancer stem cells, which correlated with the metastasis detected at that time. This is another case, triple negative, highly aggressive primary tumor, who had shown local relapse. She had a small tumor, no involved lymph nodes, but a high Ki-67, and she was PD-L1 positive. We analyzed the patient post-neoadjuvant chemotherapy with doxorubicin, cyclophosphamide, paclitaxel, and the checkpoint inhibitor pembrolizumab. She showed a partial response, had surgery in February 23, followed by radiotherapy, adjuvant chemotherapy, and pembrolizumab again. Here you can see how the circulating cancer stem cells developed in spite of pembrolizumab. She had a local relapse, which was surgically removed, but her cell numbers further increased. So you can see that the circulating tumor cells correlated with this local relapse. Here, the case in question from before. This was a 47-year-old female with breast cancer, and she had long ago diagnosed the breast cancer. It was estrogen receptor positive, progesterone receptor positive, and HER2 low positive, and an intermediate ratio of Ki-67. She had surgery in 2016, followed by radiotherapy. In 2017, she had a local relapse, had a re-surgery in 2018. As you can see, her circulating tumor stem cells went down with the tamoxifen, but after she stopped tamoxifen, she had an increasing number of circulating stem cells, and she then had a metastasis confirmed by biopsy. During endocrine treatment, her circulating stem cells were low and then increased in connection with metastasis. This is a patient with a colorectal cancer, which was diagnosed in May 23, had surgery, and she had adjuvant chemotherapy with FOLFOX and an antibody. She went down with her circulating cancer stem cells, but then came up again. In January 25, there was suspicious lesions, and indeed she had metastasis detected. So the circulating tumor cells can predict metastasis or the looming risk of metastasis formation. This is another patient with colorectal cancer, and it was KRAS mutated. And as you can see, he had FOLFIRINOX before surgery, and then he had complementary therapy, and all the time his circulating cancer stem cells were low, And then, shortly before the liver metastases were detected, the circulating cancer stem cells went up. And after surgery of the liver metastasis, they went down, and he is in complete remission at the moment with no cancer stem cells detected at the moment. I showed you some cases. Are there any questions in this?
Yes, there are a lot of questions, so this will be a long question round. One question, I think for case number 3 and 4, but also for case number 10. Do you have any experience of patients with radical remission?
Yes, we do have, and that's mainly the patients under endocrine therapy. And then we have quite a lot of patients who are constantly without circulating tumor stem cells, and they are all in complete remission. The main experience we have with endocrine treatment in breast cancer patients.
What is more effective for eliminating circulating cancer stem cells, curcumin or artesunate? And can you do something for your lifestyle or reducing risk of recurrence with some exercises?
Well, it's known that sport is a good way to reduce the risk of recurrence. Actually, we don't have any experience with patients with low or with good lifestyle for a longer time, whether the stem cells can be kept low. We have analyzed the curcumin on the tumor spheres that have been grown from patients, and yes, curcumin was effective on these patients. Other substances like the taxanes were almost not effective on the cancer stem cells. Artesunate, we don't have enough experience yet.
Can you test all medicines, immune medicines, for the effectiveness at eliminating the circulating cancer stem cells?
Well, what we can do is we can grow the cancer stem cells and then test different substances on these grown spheres, whether they are able to destroy the spheres. Yes, that we can do with any substances.
How often should this be tested? So the substances against their cancer, can the effectiveness change over the time?
I think it can change over the time, also dependent on the therapy the patients receive. For high numbers of spheres, we would recommend to do a more height testing, like every 2 to 3 months. But if there are no spheres and the therapy is not changed, or without therapy, if there are no spheres present, I would suggest it's sufficient with once half a year or a year.
For case 8, armed with information that the circulating cancer stem cells were high, could complementary treatment be applied instead of or as well as conventional therapies?
I think it could be. We have not much experience yet. It can also be repeated, the endocrine treatment, but yes, you could try to apply natural treatment, because due to the increased stem cells, the guideline medicine will not recommend any treatment.
How accurate is the stemtrac assessment of KE67? Does it change with time after treatments?
Yes, I showed in a previous case that the KI67 can change, but this was all done on tumor material or metastasis. We can test it also on the circulating tumor cells and the circulating stem cells. And I can tell you it changes quite considerably. So the question was already posed before, and again here, there is the possibility that the circulating epithelial cells are few or missing, but cancer stem cells are high. And this is shown here in a 68-year-old female patient with metastatic lung cancer, a large tumor with involved lymph nodes. She had chemotherapy before our analysis with carboplatin, pemetrexed, and checkpoint inhibitor pembrolizumab. And she had radiotherapy of brain metastasis. And then she was switched to pemetrexed and pembrolizumab, had a stable disease, but when she discontinued pembrolizumab, the PET-CT showed again multiple metastases, and we did not find any circulating epithelial tumor cells. And this can be due to the fact, which we observe frequently in far advanced tumors, that the epithelial antigen, which we use as a search antigen, is downregulated, so we can't find these cells. But the tumor spheres were high, and so here the spheres are more helpful than the epithelial cells because she has downregulated the epithelial antigen on these cells. This is a peritoneal carcinoma, and again, you can see that the circulating epithelial cells are present in this case, but they are quite low and stable. But here on the niraparent rib, the stem cells increase in numbers, and the patient had also clinical deterioration of disease. And again, here a sarcoma, which also is problematic because only part of the sarcoma cells may have expression of epithelial antigen, and she always had constant low numbers of epithelial antigen positive cells, but in the beginning she had very high numbers of circulating stem cells, a relapse which was surgically removed, and now her stem cells have gone down, but they have not disappeared, and a month later metastatic disease was confirmed. In conclusion, we are able to identify the most important subpopulation of the circulating epithelial cells, which have proliferative capacity and are able to expand clonally. This is reflected by the number of tumor spheres, which correlates with the aggressiveness of the primary tumor. Patients with a high risk of metastasis have an elevated number of tumor spheres, and more than 300 or 350 tumor spheres is an indicator where we should look for metastasis. When should we look for stem cells? You can, for example, look for stem cells after completion of the primary tumor to assess whether the remnant tumor cells are aggressive and whether the risk of metastasis formation is high. In a case where CETCs, the circulating epithelial cells, increase during a still complete remission, it can be used to find out whether this is due, the increase in CETCs, to cells with growth potential, the tumor stem cells. In some cases, if the number of circulating epithelial cells is low or undetectable, but the clinical findings indicate disease progression, we can often detect high numbers of tumor stem cells. And in some cases, CETCs remain constant after the end of therapy, and then suddenly the number drops drastically. This can be due to reseeding, to cells getting back into the metastasis, and there the tumor stem cells can be also increased. And then in cases where we can hardly detect circulating epithelial cells, we can use the stem cells for therapy monitoring. So the benefits for the patient: early detection of risk of metastasis. The circulating cancer stem cells allow us to assess the tumor aggressiveness. Then the personalized therapy. Stemtrac can help physicians to tailor treatment to the specific characteristics of the patient's tumor. We can monitoring treatment effectiveness if the stem cells respond to the therapy. And like I showed, long-term follow-up after treatment, for example, endocrine treatment. Regular testing allows for early detection of the risk of tumor recurrence. This is now the end of the cases. Are there any questions?
Yes, there are some questions which are fitting quite well here because it all are questions, referring to patients and to the health of patients. So first, does growth of circulating cancer stem cells always mean relapse, or could it be a result of infection or other medical condition?
If it's a considerable increase over 300, we believe that's not only due to infection. I would like to emphasize that EBV infection might here play a role, but it always is EBV infection can also lead to a relapse. And it's always an indicator that the cells have been activated.
Can you please point out how you divide the circulating cancer stem cells into low, moderate, or high levels? And if there is a safe level of circulating cancer stem cells?
Well, we detect very low numbers like 50 or 100 cancer stem cells per ml in patients remaining relapse-free. But if it's above 300 circulating stem cells per ml, this is an indicator that there is something going on in tumor growth.
And is there a significant change in counts of circulating tumor cells, as well as you mentioned right now, stem cells?
They can go parallel, but circulating epithelial cells are often much higher than the stem cells, because stem cells are only a fraction of the cells, but in very low counts, often all of the cells have stem cell potential.
If the circulating tumor cells rise, so matrix, but the number of cancer stem cells remains low, what could be the reason for that?
It can be release of epithelial tumor cells which have no growth potential, and we often observe this also in autoimmune disease, that the circulating epithelial cells or epithelial tumor cells are high, but with low stem cell potential.
What level of confidence can a physician have in making critical treatment decisions based on the results of stemtracs? Do you have any references for publications, guidelines, or reference hospitals that currently support stemtrac?
No, we don't have that. We have analyzed the patients more recently, but we have done repeated analysis from the same blood sample or from double blood samples, and we have again found very comparable numbers of stem cells, and we are just in process of doing a study on pancreatic stem cells and how they predict relapse. So this is in cooperation with the University of Regensburg. But still, we do not have any published results yet, apart from cases on the circulating stem cells. So now I will show our new scientific results. which can advance our understanding of tumor development. And this is in cooperation with the University of Regensburg on pancreatic cancers. And here we take tumor spheres which have been grown from patients with pancreatic cancer, and they are placed on the chicken allantois membrane, which is highly vascularized, and compare them also to the same tumor placed with tumor material on this membrane. And then we can find growth of tumor, and this tumor can then be sectioned and analyzed by the pathologist. And that's the results here. From pancreatic cancer, we can find tumor spheres, and again, they are positive in the typical stem cell analysis. And then they are placed on this CAM membrane, and they form small tumors, but which are visually directly visible. And then these tumors can be further analyzed for size and development. And we can section the small tumors, and then we can look for patients' antigens or for chicken antigens, and we can distinguish the human tumor development from the chicken allantois membrane histologically, and can show that these tumors are from human origin. Here, one case where we post-surgery found a lot of CETCs and spheres, and then after surgery, numbers declined. This patient then received FOLFIRINOX, and he is in good condition now. As I showed, the tumor growing, and it can be analyzed by histology. This is a new way to use patient-derived xenografts on the chorion allantois membrane, other than in mice, and it's very successful. If we apply tumor spheres, 90% of the samples grow into a tumor. We can do a histological analysis on these xenografts and compare to the primary tumor. And this could become an integral part of drug development, because we then now can test different drugs for forming vessels, for screening of influence on the tumor, and further biomarker discovery. The number of tumor spheres in pancreatic cancer is directly, again, associated with the aggressiveness of the primary tumor, and patients with an increased number of tumor spheres before surgery are at risk of rapid disease progression. Now I'm finished with my part. Are there any more questions?
Yes, there are more questions for discussion. One question: how does stemtrac uniquely contribute to guiding cancer treatment decisions compared to conventional monitoring methods? Are there types of cancer stemtrac is more recommended for?
We cannot recommend it yet because it's not in the guidelines, but we are convinced that the stemtrac, on one hand, detects the risk for recurrence much earlier, and all the other treatments are dependent on imaging. And for imaging, the metastasis must have reached a certain size, and as usually it's called incurable. But we might contribute to earlier detected and then contribute to cure.
Some general questions for cancer: are the people more vulnerable to recurrence as they get older?
Well, that's statistical analysis, yes. With aging, the cancer risk increases, and this may be due to lower immune system or lower effectiveness of the immune system with age.
Can you point out, please, again, what does it mean if the circulating epithelial tumor cells go down, but the cancer stem cells goes up after treatment?
Yeah, this can have different reasons. One is that the epithelial cells transform into less differentiated cells, which acquire stem cell properties, or that the epithelial cells go back and into the metastasis, but the stem cells are still present. So there are several ways to explain these cases. We have to observe them for a longer time in the future.
One last question from my part. A patient is showing a steady reading of 150, I think, circulating cancer stem cells. What therapies have you seen to help lower the numbers?
If they are stable, we need not try to eliminate them, because if they are dormant, they are not accessible to any treatment. And if they remain stable at this low level, I think it's just go ahead with the current treatment or the current lifestyle and not care too much about eliminating them completely, because the dormant cells are very difficult to eliminate.
And referring to the circulating tumor cells, is there any difference?
If they seem to be dormant cells, and it's very hard to try to eliminate them, and as long as they don't increase in numbers, I don't think you need to care too much to try to eliminate them.
All right. So thank you very much.
Thank you.